Shall we start, sir?
Yes. Good evening, everybody. Today's topic is benign prostatic hyperplasia. Dr. Farooq, who is our consultant, will moderate, and Dr. Madan will present. Over to you, Dr. Farooq.
Good evening, sir. Good evening, everybody. Today's topic is benign prostatic hyperplasia. It's a vast topic, but we try to cover all aspects. So now, Madan, can you start?
Uh, Good evening, everyone. Today, my topic of presentation is on benign prostatic hyperplasia. Uh, in this presentation, I'll be mainly talking about the definition, the risk factors, the pathophysiology of BPH, the clinical picture, diagnosis, and management of BPH. So, by definition, benign prostatic hyperplasia is a histological diagnosis in which there is an increase in total number of stromal as well as glandular epithelial cell within the transitional zone of the prostate gland. The various terminologies that are associated with the BPH are benign prostatic hypertrophy. Benign prostatic hypertrophy is an old term for benign prostatic hyperplasia, which describes the increase in cell size alone rather than increase in the cell number. Benign prostatic hyperplasia results in benign prostatic enlargement in some but not in all men. This enlargement in turn leads to benign prostatic obstruction as well as bladder outlet obstruction. While benign prostatic hyperplasia alone does not require treatment, if it is associated with benign prostatic enlargement and benign prostatic obstruction, which is usually associated with the lower urinary tract symptoms, usually requires treatment. As far as the prevalence of benign prostatic hyperplasia is concerned, usually it increases with increase in age, with the prevalence rate of 8% in men between 31 to 40 years of age, 40 to 50% in men between 51 to 60 years of age, and 80% in men more than 80 years of age. In the next couple of slides, I'll give a brief talk on the anatomy of the prostate gland and the prostatic growth before continuing my presentation on the rest of the BPH topic. The prostate gland is a partly glandular as well as a partly fibromuscular structure. Its 50% volume is composed of glandular tissue, 25% is formed by the involuntary smooth muscle, and the rest of the gland is formed by fibrous tissue. The weight of the prostate gland is between 20 to 25 grams. The size and shape of the prostate gland resembles as that of the chestnut, which lies below the urinary bladder and above the urogenital diaphragm, covering the first part of prostatic urethra. The prostate can be divided into distinct anatomical zones based on identification by transrectal ultrasound. The transitional zone is the smallest zone of the prostate, which occupies 5 to 10% of the total volume of prostate. The transitional zone is separated from the rest of the zone by a distinct fibromuscular band, and BPH is more commonly occurs in this zone. Next, the central zone. Central zone approximates 25% of the glandular substance. Central zone is a wedge shape and it forms the base of the gland, and it extends up to the apex of verumentinum. The peripheral zone, the central zone covers the ejaculatory duct as they course through the gland. Next, it is the peripheral zone which forms the rest of the glandular structure. It surrounds the central zone from below and behind. Finally, the anterior fibromuscular stroma, which is a non-glandular prostate tissue, which is composed mainly of collagen and smooth muscle, it anatomically continues as anterior visceral fascia. Next, it is the prostatic growth and the role of androgen in prostate growth. The prostate, like rest of the sex accessory tissue, is stimulated in its growth, maintenance, and secretory function by the continued presence of certain hormones and growth factor. Important among them is testosterone. Testosterone originating from testes accounts to 95% and from adrenal gland accounts to 5%. And it is a major androgen stimulating the prostatic growth. Although testosterone is a primary plasma androgen, it appears to function as a pro-hormone in the sense that the major active hormone in the prostate is 5-dihydrotestosterone, which is converted with the help of 5-alpha reductase enzyme. And the hormonal regulation of BPH is mainly played by the estrogen as well as the testosterone receptors. The activity of 5-alpha reductase also plays an important role in the BPH pathogenesis. Two forms of 5-alpha reductase exist. Type 1, which is present in liver, skin, sebaceous gland, and most of the hair follicle, and type 2, which is present in genital skin, beard, scalp hair, and prostate. And prostate consists of 90% of the type 2 and 10% of type 1 isoenzyme. And as far as the prostate growth is concerned, two growth spurts can be seen throughout the lifetime of men. First growth spurt occur between after the age of 14, and second growth spurt occur after the age of 45 without reaching the baseline. Going on to the risk factor of benign prostatic hyperplasia, which can be divided into unmodifiable risk factor and modifiable risk factor. As far as unmodifiable risk factor concerned, age, the BPH incidence is more common as the men age. Next, it is race. It has been observed that Asians have lower risk of BPH when compared to white and black men. Genetic susceptibility. Familial BPH is characterized by larger prostate size and diagnosis at an earlier age when compared to sporadic BPH. Hormone level, it's a controversial issue. Serum testosterone and dihydrotestosterone concentration do not appear to be higher in men who develop prostate hyperplasia. Further, the higher serum level of testosterone and estradiol were associated with a decreased risk of future development of symptomatic BPH in prostate cancer prevention trial. The role of estrogen is unclear. There is an increase in the ratio of estrogen to androgen in the serum in older men, which suggests the possible role of estrogen in the maintenance, but not necessarily a cause of BPH. Next, it is a family history of cancer. The risk of BPH is increased in men with family history of bladder cancer, but not with the history of prostate cancer. Next, it is a modifiable risk factors. First, it is a metabolic syndrome. Conditions such as obesity, glucose intolerance, dyslipidemia are associated with higher prostatic growth rate and prostate volume than when compared to people without metabolic syndrome. The relationship is due to the increased aromatization of the circulating testosterone in the adipose tissue, which alters the testosterone to estrogen ratio. And beverage consumption, increased coffee intake is associated with uh, BPH. Physical activity as such is not associated with the BPH, but it worsens the symptom of BPH. Alcohol consumption, higher intake of alcohol is associated with lesser incidence of BPH because of the suppression of androgen. Dietary factors, vitamin A, lycopene has shown to be a positive factor in the prevention of BPH. Sir, before pathophysiology, can I take any questions, sir? Hello.
Hello.
Yes, sir.
Sir, anything? As Madan has rightly told, that prostate is an inverted cone-shaped organ which is present just below the bladder, the apex being near the urogenital diaphragm and base near the bladder. And most important is because of the dihydrotestosterone, conversion of the testosterone to the dihydrotestosterone, which is mainly present in the prostate gland. Over the age, the conversion will be the same. The testosterone level comes down also, but the conversion will be going on in the prostate, and estrogen level will be same. So as a result, if the testosterone levels also comes down, but the growth will happen. Anything, sir?
Madan,
Yes, sir.
this BPH can occur without enlargement of the prostate?
Yes, sir. It can occur, sir.
Possible, no?
Yes.
So we should not think that only there is a by doing PR, if there is prostate enlargement only, BPH, you should not go. Symptoms are more important.
Yes, sir.
Right?
Even enlarged prostate can not necessarily produce a symptom.
Symptoms. Right, right. Then you said physical activity. Is it physical activity which increases the risk for BPH, or is it physical inactivity?
Sorry, sir. Physical inactivity, physical activity is not per se is not involved in the pathogenesis of BPH, sir, but it worsens the symptom of BPH. I mean, if the symptom, if at all, it's present, sir.
It increased activity or less activity?
Less activity, sir.
Okay. So the physical inactivity worsens the prostate symptoms. That's
Yes,
what you're
sir.
meaning?
Yes, sir.
Okay, then you have to change there. No?
Okay, sir.
Right. Vanita, any questions?
No, sir.
Right, carry on, I think. Okay, Farooq.
Sir.
Next, it is a pathophysiology of BPH. The pathophysiology of BPH is likely multifactorial. Several processes are involved in the increased production of new epithelial gland, re-establishment of prostatic cell inductive potential, and cell immortalization due to the loss of programmed cell death. The benign prostatic hyperplasia has two components, the static component and dynamic component, which leads to the symptoms that we see in BPH. The prostatic contribution of the lower urinary tract symptoms that's seen in BPH can be thought to be as having a static component referring to the enlargement of the prostate gland leading to the prostatic obstruction. The dynamic component consists of increased smooth muscle tone and resistance. And there are several theories that's been put forward uh, for the formation of benign prostatic hyperplasia. Some of them are inflammation and androgen theory. Next, it is the pelvic reduction of nitric oxide. Next, it is atherosclerosis and pelvic ischemia. Inflammation and androgen. Uh, According to this theory, systemic and localized inflammation are associated with benign prostatic hyperplasia. Several etiologies such as obesity-related inflammation, autoimmune process, and chronic infection leads to BPH. It's been hypothesized that macrophage secretes cytokine that stimulates the stromal and epithelial hyperplasia. To support this statement, it's been proven that the serum level of C-reactive protein correlates with the lower urinary tract symptom severity. And the altered androgen environment, as discussed earlier, increased estradiol to testosterone concentration level increases sensitivity of androgen receptor, thereby stimulating the formation of prostatic tissue and inhibiting the cell apoptosis. Next, it is a pelvic reduction of nitric oxide. Nitric oxide regulates prostatic smooth muscle tone, glandular secretory function, and local blood flow. Altered or reduced nitric oxide, as observed in increased age, diabetes, and hypertension, is associated with BPH. Next, it is atherosclerosis and pelvic ischemia. Atherosclerosis, pelvic artery insufficiency leads to reduced prostate or bladder perfusion, thereby causing chronic hypoxia and ischemia. These factors helps to stimulate the smooth muscle cells of the prostate, thereby structurally changing the prostate and leading to benign bladder bladder hypertrophy, and which leads to the static component of the BPH. And the dynamic component is modified because of the increased smooth muscle tone and the detrusor activity that comes along with it. And the bladder outlet obstruction and the elevated intravesicular pressure helps to release the nerve growth factor, which enhance the bladder afferent activity. Next comes the clinical presentation of the benign prostatic hyperplasia. BPH can be asymptomatic, and the correlation between the symptom and the presence of prostate enlargement on physical examination or transrectal ultrasound assessment is poor. When symptomatic, BPH present with lower urinary tract symptom, typical manifestation of lower urinary tract symptom includes storage symptom and voiding symptom. Storage symptom includes increased urinary frequency, nocturia, and urge incontinence, and voiding symptoms such as poor urinary stream, straining to void, urinary intermittency or hesitancy, splitting of voiding stream, and terminal dribbling. Uh, According to a health professional follow-up study, in a cohort study of 9,600 men who initially had moderate symptom of BPH left untreated, progressed to severe BPH over a mean follow-up period of 5.9 years, and the progression rate increases steeply as the men aged. Potential complication of a untreated BPH includes acute urinary retention, recurrent urinary tract infection, bladder stones, bladder diverticulae, and renal dysfunction. Some of the differential diagnoses that should be kept in mind with BPH are It can be divided into urological causes and non-urological causes. Urological causes includes urethral stricture, bladder neck obstruction, prostate and bladder cancer, and non-urological causes such as in cardiovascular disease, patient can be using excess of diuretic as a treatment, or else in congestive cardiac failure because of the release of brain natriuretic peptide, patient can patient's frequency of urination increases. In neurological conditions such as Parkinson disease or stroke, which is usually associated with voiding dysfunction, and endocrine disease such as diabetic mellitus, which leads to decreased bladder sensation, decreased detrusor contractility, incomplete bladder emptying, as well as in other endocrine disease such as nephrogenic diabetic insipidus, where there is a deficiency of antidiuretic hormone, leads to increased urinary frequency. Sir, any questions here, sir? Should I stop, sir?
Hello.
Hello, sir.
Madan.
Sir.
As you rightly told, the symptoms doesn't depends upon the size of the prostate. So Vanita is asking how to measure the severity of the BPH, whether mild, moderate, or severe.
Sir. Sir, there, according to American Urological Society Symptom Index, there is a self-aided questionnaires that can be filled up by the patient itself, from minimum score to 0 and maximum score to 35. According to the score, the
You are going to put that slide later.
Yes, sir. It's going to come, sir.
Yeah, that slide is coming. Anything, sir?
Hello.
Yes, sir. Tell me, sir.
Sir, my question is to postgraduates. Any first year postgraduate or anyone is there? Hello.
Sir.
Yeah. The question is, per rectal examination, how you will examine prostate? What are the points in a prostate examination clinically?
Sir, should I mention from the digital rectal examination? Initially, it starts.
Is there? I think.
No, sir, it's not there, sir. It's not there, sir.
So the postgraduate should answer. How do they digital examination of prostate? What are the points they see in that? Can any postgraduate explain?
Can I comment upon it, sir?
Yeah, please.
Sir, first is the consent from the patient. Next, it is a patient should be made to lie in a Sims position, in a left lateral position with the knee and with the knee flexed. Next, on inspection, the buttocks should be separated to look at the intergluteal cleft as well as the verge of anal verge. And on inspection, one should look for fissure, hemorrhoids, and warts. And next, with the adequate lubrication, with the palm of the index finger, one should examine by placing the palm of the finger inside the rectum, and adequate time should be given for the relaxation of the anal sphincter. Once the anal sphincter has been relaxed, one should look for any masses, and both the clockwise and anti-clockwise direction. One should examine the presence of any masses or polyps or anything. And finally, in men, we can look for prostate. In prostate examination, one should look for the size, the consistency, the tenderness, if at all is anything there. And finally, while coming out, we should look for any presence of melena or hematochezia, sir.
No, you should also look for the obliteration of the median sulcus.
Median sulcus.
Median sulcus as prostate.
Then next is mucosa mobility. Mobility of the mucosa, rectal mucosa over the prostate gland. And whether the superior limit of the prostate can be reached, that also you should check. Because in a severe prostatomegaly, you may not be able to reach the superior limit of the prostate gland, enlarged prostate gland. Am I correct?
Yes, sir.
Yes, sir.
So
in nodules also you have to fill.
Yeah, consistency also you should see, and tenderness as you told, and median sulcal obliteration is seen in enlarged prostate. That's how when we were students, mild, moderate, severe gland, because in those days the sonography was not there when we were postgraduates. Okay.
Okay, sir.
So rectal examination was this one. When the acute retention was used to come, we used to put a catheter and then examine for the prostate gland enlargement per rectally, and lot of information will have to be gathered by clinical examination. So postgraduates should be aware of this clinical examination. Okay.
Yes, sir.
Because you have to differentiate between the fibrous prostate and enlarged prostate, because both of them they cause acute retention.
Okay, sir.
Thank you.
Madan, it is pulp of the finger, not the palm. Okay.
Sorry,
Pulp
sir.
of the finger.
Yes, sir.
Dr. Noli, sir, when we do PR, bladder
Yeah.
should be empty. That's what one point was there. No, that's correct.
Yeah, that's what, sir. Yeah, after putting the catheter,
Yes.
then we put them in same position and then examine the prostate with the same gloves. We can examine, sir.
Right. I think Vanita has put correct good points about the prostate examination in the chart box. Okay. Okay, can carry on?
Yes, sir. Can we proceed, sir?
Sure.
Madan.
Yes, sir. Sir, initial evaluation should put medical history, which should includes the evaluation of the storage symptom and the voiding symptom. This information is assessed to know the impact and severity of the initial symptom, and other history such as urethral trauma, hematuria, pain, as those kind of symptoms should be elicited. And finally, on physical examination, apart from evaluation of the abdomen, pelvis, and perineum, one should also examine the a rectal examination should also be done, as well as a neurologic examination also be done. And in medical history itself, one should assess the symptom as per American Urological Association symptom index or international prostatic symptom severity, which I'll talk on the upcoming slides. Next, it is a laboratory test. Urine analysis should be done in all patients who is evaluated for benign prostatic hyperplasia. The purpose is to identify whether pyuria, glycosuria, bacteria is present, which can be a sign of alternate diagnosis. Next, it is a prostate-specific antigen. It is usually not needed for the diagnosis of the BPH, but it is usually a indirect indicator to measure the prostate volume. Next, it is the imaging, ultrasound, KUB, and post-void residual urine, post-void residual volume should be checked for. Ultrasound KUB is done to know the burden on the kidney as well as the ureter on the long-standing BPH, as well as the post-void residual urine should be mentioned. Normal men have less than 12 ml of residual urine, but in severe BPH, the post-void residual volume can go up to 250 ml. And additional tests such as prostate imaging, transrectal ultrasound is not needed for the diagnosis. It is indicated only in the treatment choice of BPH. In certain cases, like the use of 5-alpha reductase, before starting it, the urologists need a volume of prostate volume, which is directly indicated by the transrectal ultrasound. Next, it is a cystoscopy. Cystoscopy or urethrocystoscopy is not needed in the routine assessment of BPH. It should be considered in men who has a history suggestive of urethral stricture. Next comes the dynamic testing, which includes uroflowmetry and pressure flow studies. Uroflowmetry is an office-based procedure that can help to support the diagnosis of BPH by documenting the obstruction. If the flow is less than 10 ml per hour, it is usually considered as obstruction. But in certain cases where there is a flow of more than 10 ml, but if a clinician suspects there is an obstruction, he can go with the pressure flow studies, which is an invasive method in which requires a small gauge urodynamic catheter, but it is more conclusive to the cause of symptom that's there. Next, it is an indication for urological referral. Whenever there is a severe symptom, men who develop BPH in less than 45 years of old, associated hematuria, associated prostatic cancer and bladder cancer, if it is associated, if there is a presence of bladder stone, Parkinson's disease and spinal cord injury, if BPH leads to renal compromise, and if there is a failure to medical therapy. So this chart, sir.
Madan.
Yes, sir. Sir.
Regarding that investigation,
yes,
so sir. What regarding PSA?
PSA, yes, sir.
So, sir, anything you want to answer? Nuli, sir.
The prostate specific antigen. There are cautions regarding this testing. I mean, soon after DRE, this digital rectal examination, if you take the blood sample, even in prostate is normal, it will be raised. Am I correct?
Yes, sir.
So there are certain cautions for this prostate specific antigens to take the samples, and also you have to elaborate on that. PSA as such doesn't give us much information about the prostate. It can be a post prostatic CA for the evaluation purpose. We can do it, but I don't know. There are certain problems with this test. You please elaborate on that. No?
Sir, it is actually a prostate specific antigen is not of greater importance in benign prostatic hyperplasia, sir. It is much of importance in prostatic cancer, but in certain cases where if they want to start with 5-alpha reductase, it is usually started when there is a prostate volume, when the prostate size is more than 30 grams, sir. So 5-alpha, I mean, the prostate specific antigen acts as an indirect measure for a prostate volume, sir. For example, if it is more than 1.5 nanogram per deciliter, it means there is an increase in prostate volume, so that a clinician can go with the prescribing the 5-alpha reductase enzyme drugs when it concerns to PSA in BPH.
Correct.
For medical treatment, there are some urologists, they see the value.
Sir, can I proceed?
PSA is produced by prostate gland itself or anything else?
Sir, prostate gland is prostate gland only.
Prostate gland only, no, nowhere else.
Correct.
Right. Hello.
Yes, sir.
Hello. Do you have any this one on prostate biopsy?
Sir, even though BPH is a histological diagnosis, prostate biopsy is only warranted when there is a concern about prostatic cancer, sir. Such as said, when there is a digital rectal examination done, when there is an asymmetrical field or nodular gland on palpation or increased prostate specific antigen, we can go with the prostate biopsy, sir.
But can you briefly tell us how to do that? Is there a specific needle for that, or it needs anesthesia or something like that? Because to differentiate between benign and CA cancer, we have to do biopsy only. Am I correct?
Yes, sir. Yes.
Is there any specific needle? Is there like liver biopsy needle for this prostate needle? Is there? Or
yes, sir. It's there, sir.
Do you have any knowledge on that?
No, sir.
Two-cut biopsy needle, I think. No?
It is peripherally done, no?
It can be done ultrasound guided, or if you are confident, can be done blindly also.
It is per rectal only, no, sir?
Per rectal only, per rectal. True cut biopsy needle is there, sir. That's the safest.
Yeah. Correct. You can go ahead.
Sir, and for the management of BPH, we can use American Urological Association Symptom Index or International Prostatic Symptom Score, which is a self-answered questions by the patient itself, which involves certain questions such as incomplete emptying, frequency, intermittency, urgency, weak stream, straining, and nocturia. There are totally 6 questions, and the patient himself can give a mark according to the severity, that is the symptom severity that he has. Finally, a score is totaled, and according to the score, one can differentiate BPH into mild, moderate, and severe. If he gets a score between 0 to 7, it is mild. If the score between 8 to 19, it's moderate symptom. And if it is 20 to 35, it is severe symptom. So based on this assessment, one can go with watchful waiting in mild symptom, and medical management can be done in moderate symptom, and surgery can be proceeded in case of severe symptom. So watchful waiting, it is indicated in patient with mild symptom where the AUA score is less than 7, or in rare circumstances it can be done in moderate severe symptom who are not bothered by their symptom and are not experiencing any complications because of BPH. The steps includes reassurance, lifestyle modification, examination once in 6 or 12 months, and again reassessment of AUA score to know the severity. Lifestyle modification includes limited fluid intake before bedtime or prior to travel, limited intake of mild diuretics such as coffee or alcohol, limited intake of bladder irritants, avoiding constipation, increased exercise activity, weight control, and behavior intervention such as timed voiding regimen or double voiding technique can be used. Next, the medical management of BPH. It is indicated when there is a moderate symptom or failed lifestyle modification or behavioral intervention. And before prescribing a drug, a general consideration such as the comorbidities of the patient must be kept in mind, since a cardiac patient can be using diuretic or any other condition which warrants the patient to use for anticholinergic, which affects the urinary flow. And there can be a drug-to-drug interaction if a patient is taking a vasodilator in case of hypertensive patients. The pharmacological agency.
Madan, can you go back to the previous slide? Yeah, what is double voiding technique?
Sir, in double voiding technique, to reduce the severity of symptom, the patient is educated to empty the bladder once again after the first urination, sir. So that the post-voidal urine, whatever that is there, to reduce the volume, sir, so that its symptom can be postponed to little later, sir. That's all.
And the timed voiding regimen?
So a timed voiding regimen is a technique in which we instruct the patient to pass urine once in 60 or 90 minutes, irrespective of the sensation to pass the urine, sir.
Good, you have read all those things. Farooq, there are a few questions. I think better you take.
Yeah. Madan, Vanita is asking, what is the normal amount of post PVR? I think you answered it.
Sir, it's a 12 ml in normal person, sir.
Yeah.
Around.
Is it okay, Vanita? Yeah. Sir is asking, what are the bladder irritants?
Sir, tinned foods.
You have put it as irritative foods. What foods irritate the bladder?
Sir, canned foods are usually irritated, sir. High salt diets as such.
Highly seasoned. What are the highly seasoned?
Sir,
see, these are things Indians patients we deal. No, we should know all these things. What are the Indian foods irritate the bladder?
Sir, don't know, sir.
So according to this one, we should modify our slides, isn't it?
Okay, sir. Yes, sir.
Okay.
Vanita is asking difference between AUS and IPSS score.
Sir, both have a same set of questionnaires, sir, with the severity.
Correct.
Right. Yeah, certain irritants food.
Yes, sir.
No, that is spicy foods,
coffee,
tomato-based products, carbonated drinks. You said chocolate,
yes, sir.
Oranges, grapefruits, lemons, and
fruit.
limes, fruit juices, coffee, tea, carbonated drinks.
Okay, sir.
Okay, I'm just telling this from the net. Okay.
Yes, sir.
Carry on.
Sir, pharmacological options for the management of BPH includes alpha-adrenergic blockers, 5-alpha reductase inhibitor and antimuscarinic agents. Combination therapy with alpha adrenergic blockers and 5-alpha reductase inhibitor is more effective than monotherapy with either agent, but has more side effects. Additional muscarinic therapy may be useful in men with clinically significant storage symptom, which is not controlled with the use of alpha adrenergic blockers alone. Alpha adrenergic blockers are the first line medical therapy for lower urinary tract symptoms secondary to BPH because of the faster onset of action and improves the symptom independent of the prostate size. The mechanism of action is it primarily relaxes the bladder neck, prostate urethra, and prostate smooth muscle. Secondarily, it acts by inducing prostatic apoptosis. The side effects includes dizziness, hypotension, rhinitis, retrograde ejaculation, or anejaculation. So, alpha adrenergic drugs are of two generations. First generations are non-selective, which includes alphazosine, doxazosine, and terazosine. And selective alpha adrenergic receptor blockers include silidosine and tamsulosin. Out of all this group, tamsulosin is most commonly used. Next, it is a 5-alpha reductase. The mechanism of action is to reduce the static factor, which results in the shrinkage of enlarged prostate by approximately 20 to 25% over the period of 6 months. It is indicated if the prostate size is more than 35 grams or if the PSA value is more than 1.5 nanogram per ml. There are, as mentioned earlier, the 5-alpha reductase, there are two isoforms, type 1 and type 2, and the majority that is present in prostate is type 2 isoenzyme. Finasteride is selectively type 2 isoenzyme inhibitor, whereas dutasteride is a non-selective inhibitor of both type 1 and type 2 isoenzyme. The main side effect of 5-alpha reductase or sexual dysfunction, which is usually associated with finasteride, and the specific term given to it is post-finasteride syndrome. This table explains the dosage and the duration for the administration of 5-alpha reductase inhibitor, out of which finasteride is more preferred when compared to dutasteride because of the specificity of the drug. Next, it is the beta-3 adrenergic agonist or anticholinergic. It is usually indicated in overactive bladder symptoms such as frequency, urgency, and incontinence. Beta-3 adrenergic agonist mechanism is it stimulates the detrusor beta-3 agonist adrenergic receptor to promote relaxation. The group of drugs under this are mirabegron and vibegron, in which vibegron has proven to be more efficacy when compared to mirabegron. The side effect is hypertension. Next, it is anticholinergic. It is indicated in men who do not have increased post-void residual urine. The side effects with anticholinergic such as acute urinary retention, dry mouth, dyspepsia, nausea can be experienced with prescribing these drugs. This table shows the first generation and second generation anti-muscarinic agents. Next, it is a combination therapy. Combination of alpha adrenergic antagonist and 5-alpha reductase inhibitor may be considered in some patient who fail to respond to either of the drug as a monotherapy, but the problem is because of the higher side effect in the use of combination therapy. Sir, next it is a surgical management. Can I take some questions?
Madan?
Yes, sir.
Yeah. So there are, as you rightly told, there are alpha blockers and 5-alpha reductase inhibitors. Okay. The alpha blocker usually relaxes the prostate. Okay. It doesn't decreases the size. Dr. Saurav was asking, how does alpha blocker causes reduction? I think it relaxes the prostate. It doesn't decreases the size. Only 5-alpha reductase inhibitor, they decreases the size of the prostate.
Yes, sir. Actually, he had mentioned it in the slide. That's why I asked the question.
Okay. So usually these alpha blockers are the first line. The mechanism of action is the duration they take is around 2 weeks. The patient to reduce the symptoms. But this 5-alpha reductase take a lot of time, maybe 3 months, some patients. So most of the patient urologists, they will start with 5-alpha, this alpha blockers initial treatment. And combination is nowadays is more commonly used. Anything, sir?
That's right. I think nothing more. So, how do you decide that medical therapy has failed and patient has to go for surgery? These are the indications.
Sir, preoperatively, with the history, with the AUA score itself, we have mentioned, sir. I mean, we get a scoring system, sir. For example, 8, 9, something, sir. So after the period of some time, if the patient is having the same score or increased score, that can be considered as the failure to medical therapy, or else by imaging techniques such as prostate image or post-void residual urine amount can be used to know the severity, whether it has been progressed or it has been declined over the treatments.
Right, continue.
Sir, next is surgical management of BPH. The indications for surgery includes persisting symptoms, patient's choice, refractory acute urinary retention, bleeding, bladder calculus, recurrent UTI, and renal insufficiency. The choice of procedure, surgical technique depends on the size of the prostate gland, the patient's bleeding risk, the presentation with associated concurrent stones or symptom severity, and the attitude towards a potential sexual side effect. In this, there are two water vapor thermal, first minimal invasive thermal therapy, which water vapor thermal therapy can be used. The mechanism of it is a convection water vapor energy to ablate the prostatic tissue. The method that can be used here is the urethral needle ablation technique, which is called TUNA, or transurethral microwave therapy, that is TUMT. It is indicated in patient with BPH where there is a prostate volume of less than 80 grams and for the preservation of ejaculatory function. Next, it is a prostatic urethral lift. The mechanism in this technique is to open the prostatic urethra and relieve the obstruction. The method used is the nitinol capsular anchor is connected to the stainless steel end piece by a monofilament suture, and it is tensioned in vivo to increase the caliber of prostatic urethra. Next comes prostatic ablative therapy. In this, we have monopolar transurethral resection of prostate, bipolar transurethral resection of prostate, transurethral vaporization of prostate, transurethral incision of prostate, photoselective vaporization of prostate, and finally laser enucleation of prostate. Monopolar transurethral resection of prostate, it utilizes the electrocautery energy which is passed across a thin filament loop to resect the prostate tissue from the level of bladder neck to the verumontanum. Since the current is supplied through the monopolar resector scope, a non-ionic or hypoosmolar irrigation solution must conduct the current back to the ground pad. The typical solution used in a monopolar TERP is sterile water, sorbitol, and glycine. The disadvantage of MTERP is it leads to urinary tract infection, ejaculatory dysfunction, urethral stricture formation, incontinence, and excess absorption leads to a special condition called as dilution hyponatremia or TERP syndrome. Next, it is a bipolar transurethral resection of prostate. Here, it is similar to the monopolar TERP, but the electrocautery current passes within the resecting loop. So there is a use of isoosmolar solutions such as normal saline. Compared to MTERP, BTERP has similar efficacy, but with a significant fewer adverse effects such as bleeding, duration of indwelling catheter time, and TERP syndrome. Next, it is a transurethral vaporization of the prostate, in which is the electrosurgical modification of the standard TERP platform. Here, the current is applied to the prostatic tissue by an electrode to vaporize the prostatic tissue. A variety of energy delivery system can be seen: grooved vaporate, roller ball, cutting loop. The advantage of this technique is the various design improves the tissue visualization, hemostasis, tissue ablation speed, and efficiency. Next, it is a transurethral incision of prostate. Mechanism is to disrupt the bladder neck, which allows the bladder to empty without any resistance. Method is two deep incision are made, starting distal to each urethral orifice and proceeding in an antegrade fashion through the bladder neck and prostatic adenoma distally towards the verumontanum of prostate. It is usually not done in many patient, since the candidate in this condition where the BPH with small prostate size less than 30 gram, then only we can do this technique. Next, it is a photoselective vaporization of prostate. And in this, the mechanism is it utilizes the laser energy at a wavelength of 532 nanometer to vaporize the prostatic tissue. Wavelength selectively absorbed by the hemoglobin, resulting in the tissue ablation, leaving behind a thin layer of coagulation for hemostasis. This method is preferred in older men with more complex medical comorbidities and long-term anticoagulation or antiplatelet therapy. Next is the laser enucleation of prostate. Holmium laser enucleation of prostate, OLEP, or thulium laser enucleation of prostate, THULEP, utilizes the energy generated from holmium, yttrium, aluminum garnet, or laser aluminum YAG laser. The energy absorbed by the irrigation fluid at the tip of the fiber creates a vaporization bubble that distracts the prostatic tissue with minimal deep tissue penetration. Indication is it is done if the prostate size is more than 100 gram. Next comes a simple prostatectomy, which can be done through open method, laparoscopic method, and robotic approach. It is reserved for individual with large prostate that makes a transurethral route very difficult. With this, I conclude my topic. Thank you. Sir?
Hello.
Sir, yes, sir.
Few questions are there, Madan. What is, sir is asking, Nuli sir, what is prostate apoptosis?
Cell death, sir. That is in virtue of the prostate, sir. The balance is maintained by the androgen hormones. Sir?
Hello.
Yes, sir.
Dr. Mahesh sir is asking, what are the prostate-friendly diet or food?
Sir, vitamin A rich diet is usually said, sir. It's associated with reduced risk of development of BPH, sir.
Madan?
Sir, yes, sir.
See, in clinical practice, I have a problem. In the sense, patient comes with acute retention, okay?
Yes, sir.
And we put a catheter. Patient, we advise them a surgery, but they are reluctant. You know, they will say, "We will wait." Then we'll remove the catheter, and the patient passes urine. These patients can then be put on some medical treatment and send, or surgery must in them.
Sir, if the cause is due to BPH, the patient can be counseled for the surgery, sir. And the risk, the benefits, and the disadvantage of each surgical technique should be explained to him to prefer the mode, the selective choice for him. Yes, sir. Okay. Surgery should be indicated only if the patient, I mean, in case of BPH is found out, sir.
And is there any place for still for open prostatectomy?
Sir, no, sir. I spoke to my urologist, sir, our hospital. He said throughout his experience, he has seen only one case, that too in a very large prostate, sir. So now it is not done that much, sir.
Okay. And the different methods, I mean, surgical techniques you told, all of them are available in India?
No, sir. Sir, in India, mostly, most of the time it's practiced with M-TERP or B-TERP because of the efficacy it produces.
Monopolar
also...
Continue,
so
sir.
Most commonly, most commonly TURP is the procedure done. Okay, you agree with me?
Yes, sir.
Urologists all over the country now in our nation, they do TURP. Now,
Yes.
another question of mine is after TURP, say after 1 year or so, again the patient come back with same symptoms and sometimes even with retention. What is next now?
Sir, sir, evaluation, sir, because the complication associated with the TURP itself is a bladder neck contracture, sir. That that should be assessed with further diagnostic mode, such as cystoscopy or urothrocystoscopy, sir.
Okay.
Can be done.
And even after TURP, would you like to put them these patients on these medications, anti-prostate medications?
Sir, no, sir. One tablet of this thing, sir, alpha adrenergic, whatever the tamsulosin is around, and along with the 5-alpha reductase inhibitor, it costs around 45 rupees, sir. That is approximately 1,200 rupees expense, sir. So, as medical expense concerned, no, sir, it's not preferred, sir.
No.
After surgery.
Okay. Now, after TURP, we send the pieces bits to, chips to the histopathology. Then now it comes as a CA prostate. What next?
Sir,
these are practical problems we are having in clinical practice, you know.
Okay, sir.
You did the TURP, you send it with chips, and the report comes as CA prostate. Now, what to do next?
Sir, preoperatively PSA level would be checked, sir. So,
no, true. In spite of that, sometimes the histopathology report comes as CA prostate.
Okay, sir. Sir, next the next step would be to assess the metastasis of the severity of the prostate cancer, sir.
Good.
To be checked for, sir. PET scan, MRI should be done for any.
And surgically, anything should be done for these patients. Like Sir Mahesh sir is putting radical prostatectomy, something.
Yes, sir. Yes, sir. Can be done, sir. No, sir. I don't know, sir.
Yes, sir. No, sir. I don't know, sir. There are 3 answers by you.
These are the things you should have read, no?
Prostate is removed, so I don't know, sir.
When you do a TURP, you don't remove the entire prostate. You are making a passage for urinary urine to go flow easily. Correct, no?
Yes, sir.
Dr. Noli is asking, other than the radical prostatectomy, any other thing can be done? It's hormonal dependent, no? Prostatic cancer?
Yes, sir.
What hormone?
Mainly testosterone, sir.
You want to block testosterone, what you can do?
5-alpha reductase inhibitor or testosterone receptor blockers can be given.
Surgically, anything?
Sir, orchidectomy, sir.
Is produced.
Orchidectomy, sir.
Bilateral, sir.
Bilateral orchidectomy, sir.
Farooq, there are some questions I think you can take.
Yes, sir. Dr. Sauro is asking, can mirabegron be used routinely in first-line treatment? In BPH, mirabegron may induce the patient. Hello?
Sir.
Can mirabegron can be used as a first-line treatment?
Sir, no, sir. So far, alpha adrenergic agents are alpha adrenergic blockers are used as a first line of treatment, sir. And the mirabegron is indicated when there is a overactive bladder. Along with that, when the post-void residual volume is normal, sir. It's when it is not more, we can go with mirabegron, or else it's not as a first line agent. It should not be used, sir.
Dr. May, HOLEP is widely available.
HOLEP, laser. This monopolar TURP is practiced nowadays? Any idea, Mahesh?
No, sir. At least it's very getting obsolete now. Most of them are using bipolar.
Bipolar, HOLEP or laser?
HOLEP. Yes, sir.
Right. So any other questions, sir? Dr. Noli, Mahesh, Farooq?
Madan,
Sir.
an 80-year-old man has come with acute retention of urine. Okay.
Yes, sir.
What you will do?
First catheterize the patient.
Because 5 minutes are there, we will discuss. Okay.
Yes, sir. I will catheterize the patient first, sir.
What number of catheter? How?
Sir, depending on meatal diameter, it should be decided, sir.
You will measure the meatal diameter?
No, sir. No.
Then, what are the routine sizes of the catheter?
Sir, 14, 16, 18 are most commonly.
So, which one you want to use in this 80-year-old man?
Sir, 14 size. Sir.
Why 14, man? You can go for 16, 18. 14 is too small.
Yes, sir.
Okay, so you will take a urosac and catheter, then what you will do?
Sir, I'll proceed with the investigation to know the cause of it, sir. I mean,
no, catheterization I'm asking.
Steps, sir.
Catheterization procedure I'm asking.
Sir.
Steps. Yeah.
Simple. Go fast.
Sir, the principle behind it is it should be sterile, sir. It should be
I don't want principle. You tell me. You have been given the catheter and urosac. What you will do now?
How do you catheterize? Explain, no?
Sir, patient. First, the patient must be explained what procedure that I'm going to do to him, sir. I will take the consent, make the patient lie in a supine position. Sir, next it is I will prepare the parts, sir, either with betadine, sir, mostly betadine, sir. Okay. Then more important step would be to clean the glands area, to make sterile the glands area, sir. Next, adequate lubrication must be given for the passage of yes, sir. Preoperatively gentamicin is given, sir.
Adequately lubrication means what is the lubricant you will use?
Lignogel, sir. Lignogel can be used.
What percent?
2%, sir.
Okay, how much?
Sir, the volume concerned, it complete. I mean, it can total volume of whatever that comes can be used, sir. It can be put directly into the meatus, and followed by that catheterization can be done, sir.
And next,
sir, once catheterization is done, connect it to the urinary bag, and followed by that 20 ml of water is injected to expand the balloon, sir, so that it's secure in its place.
So you will put the inflation of the bulb you will do, and suddenly there is a blood coming in the catheter. What is your impression now?
I would have damaged the urethra, sir, mostly. Or
urethra.
Yes, sir. Or,
so what you will do now?
Sir, at my level, I'll call my consultant and I'll ask for help, sir.
No. At 11 o'clock night, 12 o'clock, which consultant will take you to the phone?
Sir, I don't know, sir.
So till the urine comes, you are not supposed to inflate the bulb. Okay.
Okay, sir.
That is the important thing. Otherwise, you are in the urethra and you are inflating the bulb. That time this one starts. That is one. Second thing, you should be very cautious in chronic retention patients. There is also called as chronic retention. You know that?
Yes, sir.
What is chronic retention?
Sir, it is also called as refractory urinary retention.
The patient comes with dribbling of urine, and the bladder is distended since many days, either 15 days, 1 month, like that. In that patient, after putting the catheter, immediately you don't empty the bladder. It should be gradually. Otherwise, sudden decrease in the bladder will produce again hematuria.
Okay, sir.
If it is a chronic retention, gradually you should empty. Just block the catheter every 10 minutes and then release. Otherwise, there will be, if you suddenly empty, there will be hematuria. Okay?
Okay, sir.
Then again, you put now the patient in left lateral position and do the prostate examination. That also you should not forget.
Okay, sir.
Okay. Thank you. Thank you.
Yes, thank you, sir.
So, Madan, what is your advice to men to prevent BPH?
Sir, first it is a dietary factor, sir. As I said, coffee intake should be reduced. Carbonated drinks should be reduced. Next, it is the increase in the physical activity. As such, we can't prevent BPH, sir, but the severity of the symptom that is associated with BPH can be reduced, sir.
What else? It's all from your talk only.
Sir, after the age of 45 years, BPH is more common, sir. So if we on routine 6 months, 12 months examination, you can.
If you want to prevent BPH and its symptoms, what is your advice? You said one is, see, you have said so many things. One is metabolic syndrome, avoid metabolic syndrome.
Exercise, yes, sir. Yes, sir.
Avoid obesity.
Sir.
You have to have more physical activity.
Yes, sir.
Right?
Yes, sir.
And avoid the excessive consumption of alcohol, beverages.
Okay, sir. Yes, sir.
Anything else? All these things you only taught us now.
So, yes, sir.
Okay. Thank you. Thank you, sir. Dolly.
Thank you, sir.
Anything else?
Thank you, sir.
Thank you,
sir. Good night, sir. Good night.
Thank you. Yes,
Good night, sir.
made
Thank you.
nice, good slides.
Good
Nice
slides.
slides. Very nice. Thank you, Madan. Thank you, Dr. Farooq. Good night. Good night
Thank
to
you, sir.
everybody.
Thank you, sir.